Good morning, everyone. Myself, Professor Dr. Jayachandran from the Department of Periodontology. Today, I'm going to talk about the role of risk factor in the progression of periodontal disease. Let's see some of the terminologies and the concept behind the inclusion of this risk factor assessment in your normal periodontal charting and the importance of this inclusion. What is a periodontal risk? According to the American Academy of Periodontology, the risk assessment in your normal periodontal charting help any dental professional to predict the potential of developing a periodontal disease in a particular person and allows them to focus on earlier identification and tailor-made proactive targeted treatment for those patients who are more prone for the disease. So it is predicting, identifying early, and making a tailor-made treatment for a particular patient. That is the importance of doing a risk assessment. What is the goal? The goal is nothing but to have a long-term retention of a teeth by combining the prevention, earlier intervention, and a tailor-made directed therapy in the management of a periodontitis for a particular patient who is more prone to have a periodontal disease. So this is mainly the present day scenario. Like, have you heard of Happy Japan 21? This is nothing but in the year 2020, the Japanese Dental Association, in association with the WHO, they formed a World Federation International and set a goal in a 10 years goal plan that is in 2030. Be like when the patient with the 80 years of age should retain at least a tooth till bicuspid, that is 20 permanent tooth should the 80 years patient should possess. So that shows the importance of a periodontal care, which is right now in the World Dental Federation. But mainly, we are talking about rehabilitating with dental implants. But this Federation International, they are not talking about rehabilitating. It is retention of a natural teeth for an aged person. Now we are in the developed and developing nation. We are encountering more of elderly people, and this chronic periodontitis is commonly affecting the aged 40 years of age, and thus when the patient is at the age of 60, they will have a edentulous issue. So now, in this present era, we are not talking about a tooth loss. It is not a dental problem anymore. It is a social problem where, a patient who can't able to chew the normal food, the nutritional deficiency, and the patient will have a speaking difficulty, and the cumulative effect, they have a psychological stress to be addressed. So a tooth loss is nowadays is not a dental problem. It is a social problem. So coming to this chapter, what is a disease risk? That disease risk is the probability that an individual will develop a specific disease and or a change in the health status in a specified interval of time. That is a probability that individual may develop that particular disease. What is a risk factor is any characteristics or behavioral or exposure that has an association with the particular disease. A simple example I want to give you with the disease risk and risk factor. The disease risk is who will, like present COVID condition, who will get COVID-19. Now we know that healthcare people, the frontline workers, they are more prone to have a disease. That's why we are vaccinating the healthcare workers or frontline workers at the earliest. So that is the disease risk. What is the risk factor? The risk factor is if a patient is diabetic with uncontrolled diabetic and patient who's not wearing a proper mask and properly ventilated room, it is not there. So these are the normal risk factors. So the disease risk and risk factors is totally different. And risk factor is a causative agent that is the reason for the disease to occur, right? So now some terminologies, as I said, the risk is the probability that an individual will get a specific disease at a given period. The risk is the exposure, and it should have a disease occurrence. The risk factor, as I said, is the environmental, behavioral, or biological factor that when present, there is more likelihood that an individual will develop a disease. The risk indicator, it is a probable or putative risk factor that has been identified in cross-sectional studies but not confirmed through the longitudinal study. What is the difference between a longitudinal study and a cross-sectional study? The longitudinal study is like, from the stage like where any risk factor, like for example, a causative agent is formed. That means a patient started smoking, and the same patient will be studied over a prolonged period of time for 5 years or 10 years, and they will see the disease prevalence of a particular patient. So that is a longitudinal study, that is follow-up of the same patient for a particular time. Whereas a cross-section study is nothing but at the given period of time. If the patient is having a periodontal disease, at the given period of time, they will check who are all diabetic, how many percentage diabetic, how many percentage uncontrolled. So that is risk indicator. That is cross-sectional, not a longitudinal, right? Risk factors, whereas it is a longitudinal study. By studying from the exposure of a causative agent to the occurrence of the disease, we need to have a longitudinal study to confirm that this is the second risk factor for the occurrence of the disease. What is a risk predictor or marker? Although associated with increased risk for the disease, that do not cause the disease. I will show you the example for each and every risk factor here. You can see the risk factor, as I said, it is found out by the longitudinal study, that is from the exposure to the occurrence of the disease. A smoker, if a smoker who smokes more cigarettes, he is having more prone to have a periodontal disease. That is a certain risk factor. And diabetes, the uncontrolled diabetic with the hyperglycemic control will have a more chance of getting the periodontal disease. And the pathogenic bacteria in the form of a plaque and calculus will have a more chance for occurring the periodontal. This is a certain risk factor that can cause a periodontal disease. The risk determinant is a background characteristics. That means we can't change. The dentist or any practitioner can't have a role in the background. That means a genetic factor, we can't do anything about it. And the age, nothing. Like, the gender, like for a female patient, there will be a hormonal imbalance that can cause a periodontal disease. In post-menstrual woman, there will be a depletion of hormone that might cause a disease. So all these gender and socioeconomic status, the patient with the less socioeconomic status, they will be missing some appointment and they can't regularly follow up the appointment. So these things we can't have a control, right? What is risk marker? As I said, risk marker is that doesn't cause the disease, but that will be a clinical feature of a disease. For example, bleeding on probing, if it is present, that means the patient is have a periodontal inflammation. And the previous history of periodontal disease, they have more chance for occurring the disease. So these are risk marker. Risk indicator, like as I said, the risk factor can be identified by a longitudinal study, longer follow-up. Whereas risk indicator, now with a little amount of evidence, in a cross-section study, they found out the patient with debilitating disease of HIV and a patient with osteoporosis, where there will be a density of the bone will be affected, and a patient who doesn't have an infrequent dental visit, they will have a chance more prone for a periodontal disease. But that's not confirmed. This is cross-section study. At the point of time when you're checking the HIV patient, then they are checking the osteoporosis patient, there is a more prevalence of periodontal disease. So that is risk indicators. So what is the need to incorporate the risk assessment in your periodontal charting, in the evaluation process for diagnosis and treatment plan? Why it is very vital in your diagnosis and treatment plan? Why the risk assessment is essential? This is a simple flow chart which we normally do when the patient enters a dental clinic. When a patient enters, we will take a regular medical history and dental history and a periodontal examination in the form of gingival status and periodontal status. Everything will be taken. And what we are telling right now is, instead of directly jumping to the management, you just check the risk assessment before diagnosing or prognostic values. Before arriving, check the risk determinant. For example, check whether the patient is smoking. If the patient is smoking, motivate the patient to reduce smoking or quit smoking. And if the patient is diabetic, check the blood sugar level and whether it is a good glycemic control or poor glycemic control. Then talk about the management, because these risk factors can change the course of the disease. That's why, your treatment won't have that much of success. So if you properly check the risk factor element and inform the patient to have a better counseling, then we can modify those risk factors for a better management of a periodontal disease. After risk factor assessment, if a patient is going for a non-surgical periodontal therapy, then you call the patient as re-evaluate the patient and then check if there is a positive response, if the inflammation is reduced, then you go for a maintenance care and then you re-evaluate and check whether any regression of the periodontal finding is seen. And on re-evaluation, if the patient doesn't have a positive response, if the inflammation is not subsiding, then reassess the risk factor, ask the patient again whether the smoking he has reduced, or if he is diabetic, it's under proper glycemic control, then you go for a surgical periodontal therapy. Why we are insisting this? Because surgical periodontal therapy is an expensive affair. This is basically a big fat wedding, because the amount of material you're going to invest, the bone graft, the membranes and growth factors, it is time consuming and is very costly. So when you are doing such a high profile periodontal management, the patient needs result. So before assessing the risk assessment for the particular patient, don't ever jump into the management of periodontal disease with the expensive protocol. So after throwing some light on the risk assessment, what is the importance of prognosis in your treatment plan? Prognosis, on defining it, it is a prediction of the course or outcome of the periodontal disease. Like it is predicting how the disease will progress from now. That means on the day of examination. See, basically, when the diagnosis will tell you the exact status of the disease. It doesn't show the previous, it doesn't show how it's going to course. It will show the exact condition of the disease. Whereas the clinical examination, investigation, everything will show you the past disease activity. It doesn't show the present or the future. Understood? So the diagnosis will tell you the exact condition. So when you're coming for prognosis, you need to know the future. After knowing the future, how it's going to progress, then only you can plan a treatment, and then you can inform the patient, get a consent, and start your management. So how you're going to do it? We have to do it a bird's eye view and an individual point of view. That is overall prognosis and an individual prognosis. What are the things we need to consider in overall prognosis? It's a genetic, systemic, and acquired disease. Like you should check whether the patient is healthy, he doesn't have any systemic disease, and you should check the age and the attachment loss, whether it is correlating. For example, if you say about 30% of attachment loss, if you see in 20 years of age, he is at a high risk, because the same 30% attachment loss, if it is in 40 or 50 years of age, you can very well take the patient for the management. So age is mainly related according to the attachment loss, and the patient complaint. That means like if you're doing a oral hygiene, you're scaling and root planing, and you recall the patient, and still he is not maintaining the proper oral hygiene, he is not the patient to be considered for periodontal management with the expensive biomaterials. So all these things should be taken in the general prognostic factor. Whereas local prognostic factor, mainly you'll be checking the tooth position. That means whether the any traumatic occlusion is present, the tooth root morphology, and how is the pocket depth, furcation. Individual prognostic value of a tooth should be considered. For example, if overall prognosis is bad and the patient is partially edentulous and need a prosthetic, removal process, and in the individual tooth prognosis, that means a tooth which is next to the edentulous area, you should check the individual prognostic factor to check whether prosthesis can be placed next to that tooth which is having a questionable prognosis. So the individual prognostic value is very much important for your treatment success. The individual prognostic value has two criteria. As I said, based on the stability, that is supporting structure, there is a favorable prognosis, questionable prognosis, unfavorable and hopeless prognosis. How are you going to arrive? The first one is Quark and Cation prognostic system. It says how you arrive tooth, that means individual tooth prognosis, favorable, questionable, unfavorable, or hopeless. Because we need to check at the earliest, because any hopeless tooth should be extracted, unfavorable tooth, don't ever go for a periodontal management. What is the Quark and Cation system? The favorable is after the comprehensive periodontal management and maintenance, the stabilization of tooth is achieved and future periodontal support or tooth loss is not going to occur. That if you strongly believe that, then if the tooth is go for individual tooth will go for a favorable prognosis. That means no more attachment loss is expected. The patient is maintaining it properly, and the tooth support system is achieved after periodontal management. The splinting is removed, the tooth is standing still without any mobility, then that tooth prognosis is favorable. The next one is questionable prognosis. That means the generalized factor, the systemic factor, if the patient is uncontrolled diabetic, a local factor, it is not in the proper tooth position or furcation. So all these factor is present, or which may or may not be controlled. That can be checked at next re-evaluation. That condition, you will keep it as a questionable. That means you are not sure whether the local or systemic factor can be controlled. If you have a question, if you want to re-evaluate and check, then keep this in the waiting period. That is questionable prognosis. Don't do any periodontal management in that questionable prognosis unless you think that is favorable. The next is unfavorable. That is, once you think that local and systemic factors influencing the periodontitis cannot be controlled by the comprehensive periodontal treatment or management, the patient is not cooperating, patient oral hygiene maintenance is poor, then the future periodontal breakdown is inevitable. So that is unfavorable. So periodontal management, impossible. The hopeless is when you feel the tooth is having a grade 3 furcation involvement, grade 3 mobility, all maximum scores, then those tooth is impossible to treat and it should be knocked out before a periodontal planning is even achieved. So this is the prognostic systems you need to follow. And finally, as I said, what is the relationship? Examination, that is clinical examination investigation, it is depicting the future, the past disease activity. Diagnosis will tell you the exact current disease activity. Prognosis can predict the future course of the disease. Accordingly, you tailor-made a treatment plan for a patient. So for this, risk assessment is very much important to have a proper prognostic tool to find out whether the disease can progress in a positive way or a negative way. The risk assessment and analysis is very much important. The diagnosis requires careful examination and prognosis based on accurate diagnosis. Initially, you will arrive at a provisional diagnosis. On a further, re-evaluation, you will arrive at accurate diagnosis. After arriving at accurate diagnosis, you have to go for a prognosis. So prognosis based on the accurate diagnosis, and the treatment decision is always based on the prognosis. If a prognosis, if the course of the disease will go in a very positive manner without further attachment loss, the treatment will be tailor-made for the patient, and maybe costly material like biomaterials can be tried. So the treatment decision always based on the prognosis. So the diagnosis and prognosis will change in the course of the treatment. As I said, the initial diagnosis would be a provisional diagnosis, and prognosis also depends upon the patient, how the patient is going to respond with your treatment at a regular re-evaluation cases. So the diagnosis and prognosis will tend to change during the course of the management. So that's the difference, my friends. Before, in your normal periodontal practice or any dental practice, they will do a clinical examination. They will explore grade 2 furcation, and they immediately go for a bone grafting and GTR membrane and jump into the management. That is a traditional model of care which is followed before. What is the wellness model of care? What is the recent tailor-made periodontal management for an individual patient is just inclusion of 2 elements. That is risk factor assessment of an individual patient, and then the prognostic system of an individual patient of an individual tooth or overall prognosis. If you include those 2 elements and then properly re-evaluate, it is called the wellness model of care. So thus the shift in the periodontal management has taken place. Okay, now I will end this lecture with a small example how a risk factor can play a role in the progression of periodontal disease. First, the risk factor, among the risk factor, I will take this diabetes and how a diabetes can influence the progression of periodontal disease. This is a common thought, that is a chronic periodontal disease in a long-standing manner can affect the glycemic control of a patient with diabetes, and which in turn will influence the progression of periodontal. This is a thought. That means a two-way relationship between a person with diabetes, uncontrolled diabetes, and a chronic periodontal disease. How? let's see the pathophysiology here. Who is under the risk? So this is the risk factor assessment when you're going to do if a patient is having a diabetic. So if a kid is having diabetic of type 1 and a poor glycemic control, then he is have a more increased risk for getting the periodontal disease. So the re-evaluation should be recall visit should be very often you should do for the patient with the poor glycemic control. Then you come under that dude with diabetes with poor glycemic control, he will have 3 times more chance of acquiring a periodontal disease comparing the dude without diabetes. And thus, a person with diabetes, with good glycemic control, there is no risk of developing the periodontal disease. So the game changer is nothing but the poor glycemic control. What I'm talking about poor glycemic control. The glycemic control is nothing but it is not a one-day match. It is a test, like a test match to know the blood sugar level of a particular patient over a prolonged period of time. A one-day fasting doesn't do any good for a periodontal status. So how we are dealing with this? We are going for a testing of HbA1c. That is the hemoglobin, which is a protein which is present in the blood that is bind to the RBC. And this, when the blood sugar level increases, that will have a binding towards this hemoglobin. And this hemoglobin, the main function is carrying oxygen all throughout the blood, all throughout the body. So by checking the blood glucose level, like in the oxyhemoglobin and the hemoglobin, he will have values. So if a value is below 5.7, then it is normal. If the value is 5.7 to 6.4, then you are in the borderline. You are maybe prone to get the diabetes. And if your glycemic control is 6.5 higher, it is not in a good state. It is the person with diabetic is confirmed. So the glycemic control should be checked for the patient, and then we should decide whether the poor glycemic control don't go for a periodontal management unless the glycemic control comes under control. So how a poor glycemic control can lead to a progression of periodontal disease? The first one is the primary neutrophil function, that is the acute inflammation. The neutrophil function of chemotaxis and phagocytosis will be affected. There is sluggish movement of neutrophil, chemotaxis won't be there, and phagocytosis function also that will be defective. So a microorganism can easily breach the epithelial barrier and can enter the connective tissue and can lead to connective tissue loss without being counterattacked by the neutrophil. So thus, a progression of periodontal disease is more faster in a person with poor glycemic control. The second thing is when the microbial load increases and if it goes to a chronic inflammation, the macrophage and monocyte will deliver the pro-inflammatory cytokine, which can counter the antigen. This, in the poor glycemic control patient, will be hyper-responsive, and monocyte and macrophage will be hyperactive. So it will produce more amount of pro-inflammatory cytokine, and that will be creating a lethal effect in the connective tissue. So the attachment loss is inevitable. So to add on, as you all know, when the blood glucose level increases, this glucose molecule will adhere to the protein and lipid in the form of advanced glycated end product. This advanced glycated end product, normally it will be present in the normal people, but in the person with diabetes and hyperglycemic patient, if the glycemic control is poor, these AGEs, the advanced glycated end product will be in more amount, and that will interfere in the collagen metabolism. So an impaired or defective collagen will be formed, which will be easily broken down and leads to poor healing. Thus, in a person with the poor glycemic control will lead to poor neutrophil function in the form of defective chemotaxis and phagocytosis, and hyper-responsive monocyte, which will lead to release of increase in pro-inflammatory cytokines. And third thing is increased amount of advanced glycated end product, which will interfere in the collagen metabolism, which will lead to EC breakdown and poor healing. Thus, the poor glycemic control patient will affect first in the neutrophil, second in the monocyte, plus the clinical change which you see in the form of clinical attachment loss. This is one small example of risk factor. This is again a chain shows a periodontal infection, the loss of diabetic control, hyperglycemic state, Then AGEs will be increased, which will lead to hyper-responsive monocyte and pro-inflammatory cytokines will be increased, periodontal tissue destruction, and again there will be inflammation. So this is the main risk factor assessment when you do in a diabetes, how the diabetes can influence the periodontal disease. Okay, now after explaining the detail about the risk factor assessment and the prognostic value in your treatment plan. So a small example like of the present scenario, if during this COVID, who is most at risk for COVID virus? Now they said it's the frontline workers who are more close to the proximity to the patient. And that's why, like, I mean, the government has vaccinated the frontline workers at the first come, first serve. So basically, this is the risk assessment of how people who will be getting the COVID. Most of the doctors are affected by the COVID. We all know that how many lives were we lost in our medical fraternity. So this is the risk of acquiring the disease. Why certain people are vulnerable to complication? Why we are vaccinating a person with above 45 years age with a systemic problem with the diabetes? So they found out those person with diabetic and those person with other systemic problem will have more chances of COVID death. So this is checking again a risk assessment and checking who are more prone for periodontal disease, I mean COVID-19, and whom to vaccinate first. Now see, for example, as I said, the risk and the prognostic assessment should be carried out throughout, and it can be modified every time. The prognostic is modified, the diagnosis can be modified, treatment plan can be modified after reassessing, right? After reassessing the prognostic, how it is progressing. So here, like the COVID-19, the management of COVID-19 changed from time to time. You know that, like, I mean, nowadays the treatment regime is different compared to the treatment regime which we followed in the first wave. So we have to do a longitudinal study to assess the risk factor and the prognostic value of a particular disease and then change the treatment plan. That's the importance here. I want to insist here, like your risk assessment and your prognostic assessment tend to change, like, I mean, tend to be checked on the patient at regular interval, and you can change your treatment plan according to the prognosis of the patient and the reevaluation. So now, after finishing my lecture, let's conclude by saying measurement of a risk assessment and then measurement of a risk factor and assessing the risk factor by eliminating or reducing as many risk factors as possible by proper counseling with the patient will improve the disease prevention and the treatment outcome. So that's the main idea of taking this lecture. And coming to the assessment session, let's have an assessment session about my lecture with 5 questions which I have framed here. The first question is, which of the following is not clearly identified risk factor for periodontal disease? I will repeat again. Which of the following is not clearly a risk factor for a periodontal disease? Tobacco smoking, diabetes, osteoporosis, subgingival pathogenic microorganism. Smoking, I have told you in my lecture how a smoking can cause a periodontal disease. I said about the neutrophil hyperresponsive monocyte AGEs. So that is the real indicator. That means risk factor can cause a periodontal disease. Smoking again will cause a periodontal disease, that is proven. Subgingival pathogenic microorganism, we all know that periodontitis is caused by a group of specific microorganisms, and that results in a periodontal bone loss. So osteoporosis, as I said, HIV, osteoporosis, or what? Risk indicator. That is done by a cross-sectional study, not on a longitudinal study. The osteoporosis can't cause periodontal disease. Periodontal disease can be seen in the osteoporosis patient, right? This is this indicator. So the answer is osteoporosis. The question number 2, which of the following statements about risk factor is not true? I will repeat again, which of the following statement about the risk factor is not true? First one is they are identified through cross-sectional study. Second, they are part of the causal chain. they may be environmental, behavioral, or biological factor. The fourth one is they may be modified through interventional studies, which is not true. Fourth, they may be modified through the interventional studies. True. If a patient is smoker, we can counsel the patient and smoking can be quit. Or if the patient is hyperglycemic control, the patient can be come under like on proper nutritional and diabetologist, we can control the glycemic control. So it can be modified. They may be environmental, behavioral, biological factor. Yes, the risk factor is environmental, behavioral, or biological factor. Causal chain, yes, it is part of a causal chain which we encounter in a life cycle. They are identified through cross-section study. A big no. I told you, from the occurrence, exposure of any causative agent to the occurrence of the disease, we need to have a longitudinal study. That means a long-standing study of a particular patient. We need to undertake to check the particular risk factor. So the first one, cross-sectional study, is a wrong answer. It is identified by a longitudinal study. Question number 3, the presence of risk factor may predispose a patient to develop periodontal disease. Second, the presence of risk factor may also influence the progression of the disease. Understood? The presence of risk factor that will make the patient to develop the periodontal disease. Second is it will influence the progression. 2 points. So both statements are true, both statements are false. The first statement is true and second statement is false. And the reverse way, the first statement is false and the second statement is true. Which is correct? A risk factor will have a clear indicator it will cause a disease. So first point is correct. Second point is it will influence the progression. Obviously, it will influence the progression of the disease. If a patient is smoker, continuing smoking, there won't be any improvement. The progression of the disease can't be counterattacked by a simple management of periodontal disease. So both statements are true. Question number 4, which of the following is not a risk indicator for periodontal disease? As I said, risk indicator doesn't cause a disease, right? HIV and AIDS, osteoporosis, infrequent dental visit, and they are all risk indicators. It is clear cut. It is everything is a risk indicator. That means a patient with a debilitating disease with a immunosuppression, HIV, or osteoporosis patient, or infrequent dental visit, there will be a periodontal problem. But these 3 things won't cause a periodontal disease, but periodontal disease can be seen in all 3 conditions. So it is done in a cross-sectional study, not on a longitudinal study. And question number 5, the following risk factor can be modified: age, smoking, genetics, and sex. Here, as I said, the age, the genetic, and the sexual relations, everything is background characteristics that cannot be changed. Like a female with a hormonal imbalance or a postmenopausal woman, like that cannot be under our control. Genetic, age, nothing under control. But if a patient is smoker, with a proper counseling, we can modify the risk factor. So smoking is one of the risk factors that can be modified. Question number 6, identify the correct sequence in the clinical care: examination, diagnosis, treatment, and prognosis. Examination, treatment, diagnosis, and prognosis. Examination, diagnosis, prognosis, and treatment. Examination, prognosis, diagnosis, and treatment. Here, which one is correct? As I said previously, examine, diagnose, treatment, and then prognosis. That means after the management, they will do the prognosis. But now the scenario is different. We are including the risk assessment and prognostic assessment before the management. So which one is correct? Examination of the past disease activity, diagnosis of the present disease activity, prognosis to check the future disease outcome, and then do the management. So third option is correct. Finally, a clinical scenario to end with. Here, a patient, 53-year-old male patient, presenting with the chief complaint of bleeding gum while brushing, and he wants a clean mouth and a healthy mouth. And the initial diagnosis was made, and it is a localized chronic periodontitis. He was seen for periodontal comprehensive care, a non-surgical periodontal therapy, including oral hygiene instruction, splinting, scaling, and root planing was done. An antimicrobial therapy in the form of local drug delivery was prescribed. And then surgical therapy was included. Pocket reduction surgery using guided tissue regeneration and growth factors were done. And 12 months after the treatment, a periapical radiograph was exposed. This is a pre-operative and a post-operative IOPA here. You can see. And pre-operative picture, you can see the angular bone defect in the premolar, second premolar. And post-operative picture, you can see a splinting was done, and it is the bone was regenerated. So what do you think about the individual tooth prognosis of that tooth? Here, as I said, the prognostic assessment chart, favorable, questionable, unfavorable, or it is totally going for extraction. So which one is favorable or questionable? Here, there was a defect, so it should be a questionable until the splinting and splinting was done. Once the splinting was done, then there was a little improvement in the clinical finding, and a bone regeneration was taken place. Now, the questionable prognosis turned to favorable prognosis. So thus, the prognosis of individual tooth will differ at different treatment option. So thus, clinical scenario, okay, another question if I ask, if the same amount of bone loss, if it is seen in 25-year-old patient, and the same patient with the same amount of bone loss will be seen if it is seen in a 50-year-old patient, who will be having a better prognosis? Somebody said young age patients, then it is wrong, because the amount of exposure and the amount of defect should be correlated. So if the 50-year-old patient getting this much amount of defect after a long time exposure, then that patient, if the risk factor or if it is modified, then it will have a better prognostic value than a young patient with this much amount of bone loss. So the age is not a factor, like, I mean, that means young age will have a better prognosis. It is a big no. It is depending upon the exposure and the defect. So thus, I want to conclude, in your proper periodontal examination, the risk assessment and prognostic assessment is very much important in your better management of a periodontal disease in your clinical practice. So I thank you for the opportunity and all the best for your reading. Thank you.